If someone has not had immunotherapy frontline and they have greater than 1% PD-L1, I will use pembrolizumab. That's actually based on trial 10, Keynote trial 10 that I actually led. There's no doubt that that's an improvement over standard chemotherapy. So we're using that. You could also use the other drugs in that setting, nivolumab or atezolizumab. Nivolumab being another PD-1 inhibitor. It's given every 2 weeks as opposed to the pembrolizumab, which is every 3 weeks. The atezolizumab is given every 3 weeks as a PD-L1 inhibitor. All three would be reasonable choices in that setting.
The therapeutic landscape in the second-line setting irrevocably altered in 2015 when nivolumab was approved based on the results of Checkmate 017, which showed a clear-cut, statistically significant, highly clinically relevant survival advantage for nivolumab given every 2 weeks compared to our former standard docetaxel. The median survival increased by 50% in the nivo arm, and that was later accompanied by a separate trial in non-squamous, non-small cell with essentially the same study design, single-agent nivolumab versus docetaxel, again resulting in a statistically significant, clinically relevant survival advantage. So nivo was approved on that basis, and it was really the first checkpoint inhibitor to get an approval in the United States. From March of 2015 till roughly a year later, March or April of 2016, at our institution we treated 175 discrete individuals with nivolumab during that period. And we went back and actually surveyed our results, and our response rates essentially matched what had been observed in the clinical trials. It was about 19%. Another very interesting observation, we saw absolutely no responses in those with oncogenic drivers, either EGFR mutations or ALK translocation. And we observed a pseudo-progression rate that was a bit lower than folks have assumed, certainly lower than what we've seen in melanoma. 5 patients out of that 175, so about 2.8%. It occurs, but it's rare, and you need to be sensitized to the fact that it truly is rare. Since June of 2016, we've begun to alter our approach. Pembrolizumab had received an initial approval in individuals with 50% or higher expression, again, second line and beyond, so we started using pembrolizumab off study, and then as of the fall of 2016, when Pembro's approval was expanded to 1% or higher in the second-line setting, and atezolizumab received approval independent of PD-L1 status, all of a sudden we had 3 separate agents available in this setting. So we really had to grapple with which one to use, what would be our clinical pathway. Atezolizumab and pembrolizumab have one relatively mundane advantage over nivolumab. They're both given every 3 weeks. Nivolumab is given every 2 weeks. And in this era of clinical pathways, at least as of the beginning of 2017, we have decided as a group in my institution, if individuals have PD-L1 levels 1% or higher, they will get pembrolizumab in the second-line setting. If the PD-L1 level is 0 or unknown, they get atezolizumab. They can still get nivolumab, but it is not strictly found in our clinical pathway. So at this point, the 2 Q3-week agents, the PD-1 inhibitor pembrolizumab and the PD-L1 inhibitor atezolizumab, are the agents of choice. But that could change, and the clinical pathways are meant to be flexible over time.
So in the setting of second-line therapy, I think we are seeing significant changes in the landscape because of the approvals of frontline pembrolizumab in patients with more than 50% expression, and the recent accelerated approval of pembrolizumab in combination with chemotherapy for non-squamous non-small cell lung cancer. What used to be second-line or refractory immunotherapy has transitioned in the front line. However, for the patients that were treated with the old standard of care, chemotherapy in the front line, we have the option between 3 immunotherapy agents in the second-line setting. One of the 3, pembrolizumab, requires testing for PD-L1. In the majority of the cases, this testing has already been performed in the first-line setting and can be used for selection of patients for use of pembrolizumab in the second line. Frequently, patients are also being treated with atezolizumab and nivolumab without the need for PD-L1 testing up front. There are some considerations regarding the practicality of using immunotherapy every 2 weeks with nivolumab versus every 3 weeks with atezolizumab that may lead to different choices by different physicians, but we don't have any data that any of these therapies is superior to the other.